Okay, so this is the second in a series of 3 linked presentations on NHP and collaborative working. It was given to a wider audience in May, with staff from all 11 practices in Newbury invited to attend. It was a follow-up to the first presentation in the series, given at the AGM, after which the CCG had asked us to facilitate a session on collaborative working. So, I wanted you to consider one question. What is in your best interest over the next 5 years? From a business perspective, as GP surgeries, from a patient perspective, what will deliver the better service, and from a worker's perspective, what will be a nicer organisation to work in? And is collaborative working a solution? Can we achieve more together? And how? It's a big topic and touches on many issues which are very current in the NHS. From increasing demand and workload, issues to do with recruitment and funding, increased regulation and scrutiny from organisations like the CQC, to concerns about new plans for 7-day working. So how can we make our lives easier, yet meet these rising demands? How can we get back more control? And this is why I'd like you to consider collaborative working. Okay, so in the May session we had 90 minutes. The first 30 minutes was given to 2 presentations, giving you information about the current NHS landscape and about your local provider arm, NHP. The second 30 minutes to get you to do some thinking individually and then with others on your table. And then 30 minutes to have open debate before deciding on the next steps. Today, my wife is kindly filling in as my mock audience. If I can first ask, during the recent election, we heard a lot about an £8 billion figure which the NHS needs. Do you know where they got that figure from?
Was it something George Osborne said by any chance?
I guess you could say so. The answer I was looking for, and one given by one of my audience members in May, was the 5-year forward view, the white paper from 2014. And do you know how they got to that figure?
I'm not really very sure.
Well, it's all about money and sustainability. So as illustrated here, with current levels of spending in the NHS, there's projected to be a £30 billion gap in funding in 5 years' time. So at the moment, through programmes like QUIP, the Quality Improvement and Productivity programmes, we're tightening this up with an efficiency saving of approximately 0.8% year on year. But this would only plug 9 of the £30 billion gap in the shortfall. So the proposal is we step change this and increase our savings from 0.8 to 2 to 3%. And this gets us to that shortfall figure of £8 billion as shown in the bottom of this table. Okay, so on this slide, what do you think the best answer is on how they plan to make that efficiency saving?
Should they plan to open up the competition?
Well, I can see why you might think that, and it's one of the many answers I received when I gave the presentation. But the one they didn't pick was structural changes. And the reason I would choose this as the best answer is because the emphasis in the 5-year forward view and the thing which seems to tie it all in together, requiring the funding and the investment, seems to be the new care models they propose. The key aims of the 5-year forward view are a radical upgrade in prevention and public health, greater patient involvement and empowerment, breaking down those interfaces between general practice, hospitals, mental health and social care, optimizing use of technology, reducing variation in care, and shifting care from hospitals to out-of-hospital care. It draws on a consensus of opinion from the RCGP, the King's Fund, the Family Doctor Association, and many others, some with slightly more elaborate titles such as the Primary Care Commissioning Piece, Evolve or Die, a stark warning for general practice. This is from the RCGP 2022, A Vision for General Practice in the Future. And again, it is about practices working in slightly different ways, combining their forces to provide better services. And the 5-year forward view has wide support. So this is a quote from the RCGP Chair Maureen Baker. we urge all three major parties to work with NHS England to set out a roadmap as to how they would implement the recommendations of this powerful report. In this article, Simon Stevens, the Chief Executive of the NHS, echoes the Forward View's thoughts on general practice, stating it is the bedrock of the NHS and acknowledging the strain and relative underinvestment that general practice has had. So to improve this, the Forward View proposes giving more power to CCGs to influence funding, taking steps to improve GP recruitment and retention, and to enable funding to upgrade primary care structures and their scope of service. But my impression is the 5-year Forward View is almost radical in wanting to shape and limit the types of way healthcare can be arranged, with clear expectations for greater collaboration between surgeries and a resulting wider scope of services provided by them. This is Jeremy Hunt, just a week before I presented this originally, on taking up his position as the Health Secretary again after his party's election victory, making his biggest priority to transform care outside hospitals, and stating we need a step change in services offered through general practice. So what are the new models of care proposed? The two I want to focus on are multi-speciality community providers, or MCPs, and PACS, primary and acute care systems. If you look at this picture, down on the bottom, in the darker blue, you've got primary care, with GP surgeries, pharmacies, social care, care homes, etc. And on top, in the lighter blue, is your hospital and your specialist centres in secondary care. MCPs are about primary care services, including GP surgeries, coming together in what we call horizontal integration. The aim? To provide more of that out-of-hospital care and a wider range of integrated services personalised to its population. PACS is when the hospital, for instance, takes over both secondary and primary care in what's termed vertical integration. It could also be another organisation, such as Berkshire Healthcare Foundation Trust, or a mature, developed GP group. For me, the question's not how can I stop this from happening, but which model suits us best. So again, thinking for our patients, the people working in these organisations, and our partnership interests. So would it be a PACS, an MCP, or status quo? And the question between PACS and MCPs is a little like the RCGP question posed last year about whether we want to be salaried or not. My feeling is we're less likely to have as much autonomy or control in the running of an organisation if it's managed by a hospital or a Berkshire Healthcare Foundation Trust than if we were to develop our own MCP. So, if, like at the vote last year, we prefer to keep our independent status and we choose to collaborate, we may prefer that MCP option. So an MCP has three broad options. Networks, which could be GP surgeries working together to provide joint services through an entity such as NHP. Federations, which are closer knit, with a legal structure to bind them. Or a merger, to form what are termed super partnerships. And what's the benefit of collaboration? Well, there's increased resilience. Through shared workload, the principle of us not having to do one thing 11 times, so we can be more efficient, generating capacity, and so giving more time for our clinicians and administrators to focus on their individual roles. The example I gave at the presentation was the Vitality Group in Birmingham, where 15 health centres covering a population of around 70,000 shared their backroom function, generating an additional 10% capacity. When I spoke with one of their comms directors, they said it just gave them back that extra bit of control which enabled them to be proactive and ahead of their game rather than reactive. They're now working with social services so their patients can access all their social needs as well as their health needs from that one site, their GP surgery. Through increased shared resource. So together we would have more people, more skills and more experience to draw on. And we would also have our network of premises and equipment. And with scale and the extra capacity, it's easier to upskill or recruit additional experience. So we could develop skills in bid writing or recruit that specialist clinician. and we would be better able to manage 7-day working if it came our way, or cope with any recruitment problems. So, rather than being 11 individual and I feel more vulnerable practices, we would be one group, better able to compete, win contracts, as well as manage increased pressures. There's improved quality. So this statement is from the Basics of Federation by the Family Doctor Association. Federation can improve efficiency, clinical governance, training and education, and quality and safety. We could improve patient experience, so the theory being a collaboration of surgeries with greater capacity, wider population base, will be more able to plan and provide local, integrated, seamless services specific to our population's needs. So we could move away from the web of disorganised care, as illustrated on this slide, where patients have numerous points of contact, to a more streamlined process, as shown here, where the patient has one key contact through which all other care is organised. It could create a happier workforce, so better capacity, meaning there's just that little bit more time to do the job. More resilience, so again, we can better withstand pressure. Through increased job security. Through more opportunity to progress in your career or develop a specialist interest, or maybe a clinic for an unmet patient need. And more peer support, through better links with other practices and closer networks with a larger group of colleagues. So why not? Well, some of the concerns are about loss of the individuality or character of your practice, loss of ownership, losing the ability to decide how your practice is run, and a worse patient experience, so patients often like that personal service and the individuality afforded by smaller practices. However, I think this is actually one of the advantages of a collaboration, either as a network or a federation, because you can maintain as much ownership and individuality as you would like. You could choose to have your access by telephone triage or through personal secretaries. You could employ physician associates, or not. You could share your payroll, or not. The choice is yours. There's flexibility. The idea for this slide came from the First for Health Federation in Newham. They developed a similar pyramid, illustrating how their practices linked in with their federation. So this pyramid is just an example. Not all practices would have to join, and if a practice does join, they can choose what they want to share. From bidding jointly for contracts at the bottom here, to sharing protocols and policies, back office function, premises and staff, all the way up to merging completely. So a practice could choose at what level they want to join, according to what suits them best. The key question is, what work would you want to keep, and what work would you want to share? And where are you on the balance scales? Are you at that tipping point between the perceived advantages and the perceived disadvantages? If we do take this forward, for it to succeed, we need full and active engagement from any practice involved and everyone involved. But do we really need to do anything? Well, the day I gave this talk in May, Buckinghamshire were having their first workshop to make collaborative working a reality. Some of us will be aware of collaborative work already happening in Hampshire and Oxfordshire. Most of us will know of GP Care, a collaboration of 100 GP practices in Bristol. And a lot has been happening since the 5-year forward view came out in October last year. There's a division in the Department of Health tasked with the job of putting the 5-year forward view into action. And as a result, in January this year, 260 sites applied to be a vanguard site, a site that would lead the way in developing the new care models with support from the Department of Health. 63 were shortlisted, 29 accepted. This map shows the 29 vanguard sites. They include MCPs in red, like the Vitality Group I already mentioned in Birmingham, and others like South Hampshire, providing an extended range of services for their 220,000 patients. PACs in blue, like the one in North East Hampshire and Farnham, bringing together home care services, mental health, community nursing, GPs and hospitals to provide streamlined services and reduce duplication. Similarly, Yeovil and Somerset are joining their GP Federation and local hospital trust together to provide streamlined joint primary and secondary care services, initially focusing on their long-term conditions with the aim of eventually holding a single budget for their population and the means to target their resource where it is most needed. And another care model, shown here in green, integrating social and medical services for patients in care homes, like in East and North Hertfordshire CCG. In addition to these 29 sites, the 34 sites that have been shortlisted but not accepted as vanguards are now also being developed as first followers. So, if we do choose to collaborate, when would we do so? This article was very current when I gave the presentation, happening just the week before. It's about a 27,000 patient practice in Derby, which had to close because of recruitment issues. The local hospital stepped in to help and is now managing and providing both the GP primary care service and the acute and secondary hospital services, i.e. it is now a PACS. So the thing that struck me was the size of the practice. It was 27,000 patients, i.e. it's not small. I thought the comments were interesting. From the LMC chair, this is a reflection of the recruitment and retention crisis in general practice, and it will not be the last practice. From the CCG chair, we see this as a good opportunity to forge stronger links between GP surgeries, primary care, and local hospitals, secondary care. So the question I ask is, how much would NHS England want to support old GP structures? And would we be better placed and more in control if we were together? Okay, so something else to consider. Has anyone heard of the Babylon app before?
Has it got anything to do with a pop group?
Good answer, however, not quite. At the presentation, nobody had heard of it either. So, it's created by Ali Parser, the founder of the Circle Group, 1 month before this presentation was first given. It's an app for your mobile phone, and this slide shows how it's advertised on the NHS Choices website as your healthcare in your pocket, providing you with access to a GP 8 till 8, 6 days a week, by telephone, video, or text. Calls can be answered there and then, or booked in advance, and all your consultations and medical records can be stored on your phone for later record. You can also access specialist care. So what do you think the price might be?
About £30 a month?
Well, that's pretty much what my audience thought, either £30 or higher. In actuality, it costs £5 per month with the first month free. A specialist appointment is £49. So what do you think? At launch, they were confident they would have 90% of British companies signed up to using Babylon within 2 months. They're working with most of the medical insurance companies. Jersey was about to sign up access to Babylon for all its residents, and there were plans to provide medical access for Rwanda from December this year. Babylon's big advantage is its easy access. Some GP surgeries are taking advantage of this and have already linked it in to their own service to ease the access issues at their own surgery. But Babylon doesn't provide a face-to-face service. It can't examine a patient, and it doesn't provide an acute emergency service. So the question is, where does general practice fit in? Are we stronger and better together? And what is in everyone's best interest? Thank you.